Maybe we're going to wait another minute to give people a chance to log on. Thank you for joining us. If you're just joining, we're waiting another minute or two to allow people a chance to log on. If you're just joining, we're going to start in a moment, just giving people a chance to log on. Okay, let's get started. Thank you for joining us on World AIDS Day to talk about mental health and HIV integration. I'm Pamela Collins. I'm a professor of psychiatry and global health based here in the United States at the University of Washington in Seattle. I direct the International Training and Education Center for Health, or ITEC, which is a network of organizations and teams that are working around the world to support health system strengthening. We work closely with ministries of health, and supporting HIV prevention, care, and treatment is one of our major thrusts. I'm also the associate director of the UW Behavioral Research Center for HIV. So these two centers are co-sponsors of this event with the Mental Health Innovation Network. And I'm here with a group of colleagues who will share wonderful programmatic policy and research insights as we advocate for and continue to learn about integration of HIV and mental health care in diverse settings around the world. Let me briefly introduce our panel. And panelists, if you can wave your hand. Ms. Belinda White is a clinical psychologist and consultant with ITEC in Trinidad and Tobago. She's based in Port of Spain. Dr. Gloria Ganezi is head of programs at the Zimbabwe Technical Assistance Training and Education Center for Health. She joins us from Harare, Zimbabwe. Ms. Janelle Brooks is a psychologist leading the mental health and psychosocial support activities at the Caribbean Training and Education Center for Health in Kingston, Jamaica. Dr. Lydia Schwastiak is professor of psychiatry and behavioral sciences at the University of Washington and director of the Integrated Care Core of the UW Behavioral Research Center for HIV here in Seattle. And Mr. James Sale is director of policy, advocacy, and financing with United for Global Mental Health. And James joins us from London. I want to orient us to this conversation very briefly. First, I want to make the point that we integrate mental health care and HIV care with the goal of providing people with holistic services that enable them to live well and to thrive. If we think of our mental health along a continuum, from no distress to defined syndromes requiring specific treatments, integrated care services can address needs along the different stages of this continuum. And we start by talking about mental health, regardless of whether there is a complaint. This includes explaining that the actions that support their overall health can also support mental health. That includes maintaining a healthy diet, exercising, nurturing close relationships and social support to promote and sustain well-being. Talking about mental health also includes educating people about mental health and substance use, providing guidance on reducing stress and strengthening psychosocial supports. We know that anxiety and depressive symptoms are the most commonly occurring symptoms of psychological distress that people in HIV care are likely to talk about. Explaining that depression is very common and does not indicate weakness or laziness can be an appropriate starting point in some cases. Similarly, explaining that substance use dependence can be treated effectively and that people do get better opens the conversation about care. Offering basic information about dementia and explaining options for individual, family, and community support can also be pertinent. Psychological treatments are effective for many mental health and substance use disorders. Many of these have been adapted for use by trained, supervised, non-specialist health workers in places where there simply are not enough specialists to do this kind of work. So for moderate depressive symptoms, for example, treatments like behavioral activation, problem-solving therapy, problem management plus, group support psychotherapy, cognitive behavioral therapy, or interpersonal therapy are all evidence-based interventions that can be first-line approaches. But importantly, our interventions need to occur outside of the clinic as well. Many of the same social and environmental determinants that drive HIV risk also increase risk for mental health conditions or substance use conditions. And these include violence, stigma and discrimination, social exclusion, economic adversities. We want to remember we're really happy that the Global AIDS targets for 2025 call for linkage to mental health services and other kinds of care for 90% of people at high risk of HIV or living with HIV. And importantly, they call for a reduction in punitive laws and policies, stigma and discrimination, gender inequality, and violence. So with that, let's get our conversation started. I want to remind you that we do have a Q&A open, and you can please put questions or comments in throughout, and we'll have time at the end to address your questions and answers. But I want to start the conversation with Belinda. Belinda, can you tell us briefly about the status of mental health care and HIV care integration in Trinidad and Tobago? And tell us about your role in this work.
Sure. Thank you, Pamela. Good morning, everyone. So I want to preface this answer by saying that our health system within Trinidad and Tobago is very segmented, meaning that we have different regions within Trinidad, and within each region, each of the 5 regions has a health authority. And so the primary healthcare facility within that region falls underneath that health authority. So our mental health system within Trinidad and Tobago falls under one regional health authority. So it's sort of separated from primary health care throughout all of the 5 regions, right? And so therein lies some challenges that arise. So if someone presents at a treatment and care site and they're in need of mental health services, what may happen is they're referred outward to a mental health and wellness center, which is in a different location, right? And therein lies further challenges, like the client may be fearful of having to disclose their HIV status again, having to go through the entire enrollment process of joining a new clinic. And also there are other challenges that arise with feedback being given by that mental health clinic to the HIV treatment and care site. So the communication between the 2 agencies could be quite challenging at the moment. With regard to my role, it's definitely to support the strengthening of integration of mental health services within the HIV treatment and care sites. And that started in February of this year, where we conducted a psychosocial assessment in collaboration with the Ministry of Health, HIV/AIDS Coordination Unit, and that really identified the core challenges that arose within the treatment and care sites, as well as it facilitated the identification of critical recommendations, that could help us move forward in achieving our goal. So that has been completed. And at this present moment, we established a technical working group. But in addition to that as well, I'm also providing support in the establishment of a psychosocial coordination unit, which is going to comprise of a psychologist, a social worker, patient advocates, established by the Ministry of Health. And finally, I'm also going to be crafting trainings for healthcare workers so that they feel more confident in their ability to identify and, as you mentioned, provide a brief intervention support to persons who present to them with mental illnesses.
That's great. So you're giving us a great example of how you're actually bringing this mental health and psychosocial support team into the middle of HIV care and treatment services, kind of at the top, right? This is a coordinating group. So
yes.
what are this group's goals and how will the group define success? If you can tell us in a couple of minutes.
Sure. So this technical working group comprises of representatives from each of the regional health authorities that I mentioned previously, and it also includes site level staff, so that's social workers, nurses, medical doctors, etc. Our primary goal is to establish a protocol that is going to really dictate the way in which the site level staff interact with the psychosocial coordination unit that is hopefully going to be established by January of 2023. That's going to be our ultimate success, the completion of that protocol and the successful implementation of it with the site level staff feeling confident in the ability to navigate the new referral system.
That's excellent. So thank you, Belinda. You've started us off by thinking about that integration requires this conversation at the level of the ministry with all the different stakeholders, and you're at this stage of bringing those stakeholders together to then figure out how the services can begin to be coordinated and the providers supported. Thanks for that. Yes. So let's move from Trinidad and Tobago to Jamaica, or I'm sorry, we'll move to Zimbabwe. And I would love, Dr. Gloria, can you first tell us about Zimtech?
Yes, sure. Thank you, Pamela. So Zimtech, it's short for Zimbabwe Technical Assistance, Training and Education Center for Health, which is a local organization and implementing partner, part of the ITEC Global Network, supporting and complementing the Ministry of Health of Zimbabwe's efforts in the HIV response. We support activities across the whole HIV continuum of care in 5 provinces in Zimbabwe, and through direct service, technical assistance, and HRH. So basically, that's Zimtech for you. And I'm with Zimtech as head of program.
Great, thanks.
Thank you.
So give us a bit of an orientation to HIV and mental health care integration in Zimbabwe. What's the status now?
Okay, so with regards to the status of mental health and HIV integration in Zimbabwe, I'll start by giving you an overview of the HIV services status, where as a nation, Zimbabwe has a high coverage of HIV services and is on path to reaching epidemic control by 2030. According to the Zimbabwe Population-Based Health HIV Impact Assessment of 2020, it is estimated that close to 87% of adults in Zimbabwe know their HIV status. 97% of them are actually on ART, and 90% of them are virally suppressed. Now, looking on the mental health front, we recognize mental health as a public health concern in Zimbabwe, including the gap on screening common mental conditions among people living with HIV. And according to the 2020 WHO figures that we have, major depressive disorders, alcohol use, and suicide actually top the list as the most prevalent mental health conditions in Zimbabwe. And on the face of this background, there are limited psychiatric specialist services emanating from the fact that we've got limited psychiatric hospitals that are accessible and affordable. We also have limited number of service providers. And in recognizing this, the government of Zimbabwe actually developed a national mental health strategy, which is basically aimed at covering mental health integration in public health care services. And this is inclusive of the HIV services. And further to this established framework, World Health Organization is actually supporting the Ministry of Health of Zimbabwe on implementation of mental health gap action program at primary health care level under the WHO Special Initiative for Mental Health. And for us, looking at where we are with the epidemic, HIV epidemic, the overarching strategy for the nation now in the HIV response is to maintain the programmatic successes that we've achieved through integrating mental health, promoting the mental well-being of people living with HIV across the whole HIV continuum of care to keep them in care. Thank you. Over.
That's great. Thank you so much, Gloria. I have another question for you. So if you and your team had to focus on one aspect of this complex process that you think would really help further the process of integration, what would that be? And what supports would you need in particular to be successful?
Yeah, so thank you, Pamela. I'll start by just giving an outline of the support that we are giving as Zimtech, supporting Ministry of Health. So as an implementing partner supporting HIV response, we prioritize mental health services across the HIV cascade, focusing on building capacity among service providers, strengthening mental health screening and referral systems. We collaborate with other organizations, leveraging on already tried and tested interventions, such as the EQUIP platform and the Friendship Bench model. And in collaboration with Ministry of Health and WHO, we train trainers who are basically clinicians with some post-basic psychiatry training. We trained them on competence-based psychological support, psychological treatment, and basically on foundational helping skills, with the hope that these trainers are going to cascade the training to non-mental health specialists to make sure that they are able to offer quality mental health services in HIV programming. We also developed a mental health integration concept note, where we are going to be training lay cadres that are going to be using a problem-solving therapy approach and referring clients, particularly within the HIV setting. And given the disproportionate number of mental health specialists and the high level of attrition amongst our healthcare providers, for me, a more sustainable approach to further the process of HIV mental health integration would be to identify more lay cadres, train them, particularly looking at peer-to-peer support among people living with HIV, and also strengthening psychosocial support groups, making sure that they become a forum for them to debrief, and also a forum to share best practices. Thank you. Over.
Great. Thank you so much. So you all are on you're about to really expand what you're doing, it sounds like, and we'll be interested to see how all of that rolls out. So let's go to Jamaica now and over to Janelle Brooks. Janelle, Zimtech has had quite a lot of experience addressing mental health needs in HIV care. Can you tell us about how mental health and HIV integration is shaping up in Jamaica?
Thank you. Morning once again. So I have to also preface this by saying that I think one of the blessings, if I may say so, of the pandemic was that there has been an increased awareness of the importance of mental health for everyone across the board. So I think that has also become evident in the work that we do here in Jamaica and how mental health services are integrated. So as it stands right now, our patients have access to the services of the psychosocial staff, which includes psychiatrists, psychologists, social workers, case managers, and adherence counselors. So when you come to the HIV clinic, you have access to all of these persons. And now we have moved to the point where some clinics have specific mental health clinics within the HIV treatment setting. So there is further integration there. Some clinics have also diversified how they offer their services, and they have evening clinics to facilitate persons who may not be able to come to the clinic doing normal 9 to 5 hours, so to speak. And we have also been able to equip our treatment sites with resources so that every client patient that comes in is screened for depression, either with the PHQ-2 or the PHQ-9. So we were able to develop a manual and equip the treatment sites with that so that persons don't always have to wait for the psychologist or the psychiatrist to come for that kind of an assessment to be done. A screening can be done and then a referral can be made to the psychologist. We've also been able to train our medical officers using the MH-GAP model so that they are better able to identify and respond to mental health concerns and maybe prescribe if that becomes necessary. And the psychosocial team really takes on the word of psychosocial. So they are catering to the psychological needs as well as the social needs. So social workers can conduct home visits to patients who are not able to come to the clinic to give medication drop-off, for example, or sometimes patients are provided with a travel stipend to facilitate them coming to the clinic. So
That's
those are
great.
some examples.
Thank you. That's a really comprehensive set of providers as well as opportunities for people to connect. Can you tell us a bit about your role specifically and how you support the healthcare workforce?
Sure. So over the past 3 years in particular, we've had a lot of training initiatives because we want to increase the capacity of the site team to be able to cater to the mental health and social needs of the patients. So quite recently, we have trained psychosocial team members in trauma-informed care because we recognize that many of our patients present with symptoms of PTSD or other trauma-related disorders. And we also understand, given the nature of life in general, most people would have had some kind of traumatic experience, and therefore it's good for all of the treatment site members to have at least that background knowledge. We've also been able to train staff members in behavioral activation, MH-GAP, like I mentioned before. And what we do is that we have monthly communities of practice where persons can come and sharpen their skills. So they're not just trained and we leave them. We meet monthly, go through case studies, case presentations, simulations, so that their skills stay sharp. And they're also able to get advice from other team members on a case as well. So we do that through our therapeutic consult group, and we have a mental health echo every month as well. And we have clinical mentors in the sites who are able to give that kind of one-on-one advice to psychosocial staff members. And we contracted a psychiatrist who was able to do one-on-ones with some clients who might have been at risk for being lost to follow-up or non-adherent to their medication. So she was able to give that added support, and we really saw some success with that as well.
Great, that sounds great. So when you consider all of these efforts, what approaches would you say have yielded the greatest success, and where would you say the challenges remain?
So one of the areas that has been successful as well as challenging is the use of the psychiatrist. So like I mentioned before, her being able to come in and give one-on-one support to some clients has been successful. And, you know, the psychosocial staff has really given us the feedback that that has been working. Part of the problem is right now there is not enough psychiatrists to meet the demand of what we need. So supply is not matching demand right now. We would love to be able to have more psychiatrists be able to give that one-on-one support, but it's not possible right now. So we're looking at various ways that we can scale up that part of the program. Another challenge that we recognize is, despite the MH gap training, some of the clinicians, the medical doctors are still reporting that they do not feel confident in treating mental health conditions or making appropriate referrals or writing prescriptions, etc. So we plan to have another refresher training next year, as well as to review how the medical officers can get continued support in that skill set.
Mhm. Yeah, that's right. I think you're raising some really important issues, both when we look across the continuum of severity of symptoms. When you have folks at the more severe end and you need that referral for more specialist care, what are some ways of getting around that? And maybe we can talk about that later if we have time to talk about collaborative care model or other ways of supporting primary care docs or HIV docs as well. But let's, so thank you for sharing with us about Zimtech's work. And I want to go over to Lydia, who is here at the University of Washington. Over to you. Lydia, you're studying the implementation of integrated care in King County. So can you set the scene for us and tell us about your work?
Yeah, thanks, Pamela, for the opportunity to share our experience in this session. So King County, where Seattle is only one part of the national effort to end the HIV epidemic in the U.S., but it's an important part, and I just wanted to highlight some important aspects. You know, the work here it highlights some important aspects of national efforts. So I think many people will know that the 2019 Ending the HIV Epidemic Initiative in the U.S. identified 57 geographic focus areas to receive federal funding to develop plans to address the HIV epidemic as tailored to their local areas. And King County was one of these 57 regions. So King County had kind of an interesting history with the HIV epidemic. It was actually the first urban jurisdiction in the U.S. to meet the World Health Organization 90-90-90 goals that ensured that 90% of all people living with HIV were knew of their infection, 90% who were diagnosed received medical care, and 90% of those who in care were virally suppressed. But excuse me, unfortunately, the past 4 years have presented some significant challenges in maintaining this success. So there was a substantial increase in 2018 in new HIV diagnoses among people who inject drugs in King County. And then over the last couple of years, there's been COVID-related disruptions in HIV testing, prevention services, and access to care. So I'll briefly describe, you're right, we're implementing collaborative care, and I'll briefly describe our experience integrating care for depression and opioid use disorder in a low barrier HIV clinic in King County. This low barrier clinic is a partnership between the County Department of Health and HIV clinical providers at the County Hospital in Seattle. And it's been a very successful part of the King County local Ending the Epidemic plan. So the low barrier clinic involves a multidisciplinary team that aims to reduce barriers to HIV care among, it's about 300 people living with HIV who are virally unsuppressed in the county. And the model was developed by some of our colleagues, Julie Dombrowski and Matt Golden, really recognizing that to achieve the goal of 95% viral suppression, they needed to reach and engage people with complex barriers to care, such as unstable housing, substance use, and chronic mental disorders, more serious mental disorders. So the clinic is really, it's open access. There are no appointments. It provides wraparound services and includes some incentives for things like getting lab tests to have the viral load measured or filling prescriptions. So it does serve a special population of people living with HIV who have complex behavioral health and social needs, but it's a model that's being scaled around the US. And we've actually, King County's actually launched 2 more of these clinics in the past year. So our integrated care model in this low barrier clinic that we've been studying over the last year and a half or so is based on the collaborative care model, which, as you mentioned, is an effective multi-component model that integrates mental health services into primary care settings. And so essentially we added a nurse care manager and a psychiatric consultant to the existing multidisciplinary team, and then implemented population-based screening for depression and opioid use disorder, measurement-based care for those disorders, and evidence-based, kind of monitoring of evidence-based pharmacotherapy and behavioral activation for depression. So there were a lot of lessons learned in the project that are informing our next steps, but mainly around understanding what mental health and substance use services are feasible and acceptable in a low barrier setting, and then what type of provider is best to provide these services, and then also what outcomes are the most important to measure. And then I'll just highlight another kind of takeaway. Another important point is that the work highlighted an opportunity for behavioral health organizations, just the recognition of the high prevalence of more chronic and serious mental disorders highlighted an opportunity for behavioral health organizations in the county to attend to HIV prevention and care. So we've actually just launched a second project that focuses on HIV prevention among people with more serious mental illnesses. And we have a one-year project that's a collaboration with 25 behavioral health organizations in the county. And it's kind of a mix of organizations. They're either mental health or substance use treatment clinical settings, or they're community-based organizations that primarily provide social services such as shelter or supportive housing, but also provide behavioral health services. But they're designed to meet the needs of individuals with serious mental illness and complex social needs, and they provide holistic care. And so the aim is to integrate HIV prevention into the services that they're currently providing.
Yeah, thank you for raising that in particular, Lydia, because I think it's important to keep emphasizing that this is a bidirectional set of relationships, that people with a primary, particularly serious mental health conditions are, in this country at least, and certainly we have evidence in many other parts of the world, are at high risk for HIV infection. And so when we talk about integration, we're also saying, how do we bring access to HIV prevention care and treatment to people who are receiving care in behavioral health or mental health care settings as well, or substance use care settings as well. So that work is very important. I want to transition to James and the work that James is doing. James, you've been an active advocate for integrated care. As you listen to the work of our panelists, I'm sure you understand the complexity of integration. Can you tell us a bit about the advocacy you've been a part of over the past few years to bring attention to the need for integration?
Yeah, absolutely. And thank you so much for inviting me to join today. I'm certainly overwhelmed by the projects and the approaches that have been described, the level of input into this really important area. It's just fantastic for an advocate like me to hear about all these fantastic approaches and projects happening, activities all around the world. And yeah, I'm not a medical practitioner or in mental health or physical health, and my organisation isn't a service delivery organisation, but we are campaigning and advocating hard for the integration of mental health into HIV approaches around the world, particularly in low middle income countries. And a huge part of that is us trying to persuade those with the finance to be able to put finances into those services and into those approaches. And one example of that work that we do is around the Global Fund. So, 2.5 years ago, we identified the Global Fund to fight HIV, or AIDS, TB, and malaria as a key global financing mechanism, which could be investing more and could be investing better in mental health within its HIV and TB work across the world. And so And why did we do this? Well, because of all of the evidence and information that's been discussed today, we know that integrating mental health and valuing and prioritizing mental health and how we approach HIV not only has huge impact on HIV outcome, but also on the mental health outcomes of those individuals and vulnerable populations, and frankly also it contributes to the rights to people of the highest attainable level of mental health and to good medical health care and to dignity as well. So we were very motivated to work on this. So what did we do? Well, there's sort of 5 key principles, I'd say, on our approach. And I'd say our first objective was to have mental health meaningfully within the Global Fund strategy. And the next one that was coming up for us in terms of the cycle was the 2023 to 2028 5-year strategy of the Global Fund, which was published this time last year. And that's what we were working towards. And, spoiler alert, that happened, and we're very pleased. And we worked with a range of fantastic partners from very different areas, including Pamela and her colleagues as well, to make that happen. So the sort of 5 principles and approaches we took to that. Firstly, and for us foremost, was to amplify the voice of people of lived experience. So everything we were doing, we were making sure that people of lived experience were involved in the design, in the development, and ultimately in being heard by those who are decision makers and those that hold power, and those that we were trying to influence. So a lot of the work we did was about promoting people's stories, literally creating events, public events, webinars, other types of communication activities for people of lived experience to talk about and to share their story, but also to go beyond that, actually to hear their technical thoughts and to hear their experiences of systems and how they think they could be improved, and not just that sort of human interest side story, but really have them involved in technical working. The second principle we had is we needed to get global consensus or multi-stakeholder consensus. So we needed to get a group of mental health champions, particularly within the Global Fund universe, to be championing this. So it wasn't just our voice or our friends and partners' voice from civil society, but it was a multi-stakeholder group. So we looked at the board and we identified governments that were particularly pro-mental health in their development and work and humanitarian work. And we worked with those to get their voices heard about mental health on the board of the Global Fund, including the civil society constituencies and the community constituencies, to make sure that there was this sort of growing momentum within the decision-making body of the Global Fund. And thirdly, and this is where a lot of the work today comes in, is we had to make evidence-based arguments. We needed to be credible. We needed those sort of punchy, short policy briefings that you see so often to be actually rooted deeply in evidence and data, and need to be accurate and correct. There's nothing worse as an advocate, particularly that isn't a medical professional, to go into a room and to promote or argue for an idea, only to have the carpet whipped from under your feet because the data or the evidence that you're giving isn't credible. So learning from the projects such as have been talked about today to make our arguments evidence-based. Fourthly, and I'll get through this quickly, targeted communications. So really trying to understand the decision makers, what they would be tuned into, what is the types of social media that resonate better with those individuals, what are the global media outlets. We worked with Pamela on placing articles, opinion pieces and comment pieces in peer-reviewed journals, for example, because we knew that's where we would be able to capture a lot of decision makers in terms of what they're looking at and what they're looking to be able to inform their decision making. And then lastly, and this is very important and links to the first point, is about linking that national and global level advocacy work. So, it wasn't just this sort of thing happening in Geneva, that we actually needed to be working with partners across the world, particularly those working within Global Fund partner countries, to be able to have joined up advocacy so that those in Geneva could feel that there was a demand for mental health to be increased within Global Fund investments at the country level, and they were feeling that, and therefore they could respond. So yeah, I sort of gave the spoiler at the beginning, in December last year, the 2023 to 2025 Global Fund Strategy was launched. We were very pleased to see that mental health is integrated throughout, not just within this sort of sections on HIV and then sections on TB in terms of technical programming, but also as a standalone point, saying that they need to be engaging with the global mental health community and national mental health communities, not just within HIV and TB programs, but as a whole as well. And we're very pleased to see that. So those 5 principles are the ones that we adopted for that advocacy approach. We're pleased that it worked. It wasn't just us, there's lots of other people involved. And that third point about evidence-based argument, well, we really rely on learning from the types of projects that have been spoken about already.
Thanks so much, James. Can you give us a sense, tell us about the advice that you might have for panelists and for listeners who want to advocate for more services and even for more funding? Because I think that's often a theme that, yes, everyone's trying to do something, but we never feel like it's adequate, right? And there's always more need than the current services or even funding can permit. Do you have any advice about how people can make their voices heard?
Yeah, definitely. So lots of different ways. Two things come to mind. One is about how we communicate what's being done. Now, as I say, I'm not a scientist or a medical professional, so I really need the way that these types of projects are being reported and communicated to be accessible to me and therefore accessible to many other people and decision makers. And I know you're all very good at this in the way you've articulated what you're doing today. For me, I completely understand. I get excited about, and I want to go and talk to other people about these things that are happening in Zimbabwe and other places, So I think being able to communicate highly scientific and medical information in lay terms is really, really important. Often the decision makers that, I come across in maybe within ministries of health, but certainly with, multilateral, they're not always, and I'd extend that to donors as well. They're not always specifically technical experts on your issue. They might have quite a wide portfolio. Quite often in donor, be that bilateral or multilateral and philanthropic donors, people are generalists having to cover quite a few different areas. And so making that information as accessible as possible, I think is really important. So communication's one. On the financing point, and this is something I think that across the health sector we struggle with, is about talking the language of finance ministries. We're very good at talking the language of health ministries, but we have to also talk the language of finance ministries. And as advocates, we often have to help health ministries with communications to finance ministry. So what can we support in terms of providing return on investment arguments or cost effectiveness arguments that we know are going to play well with those that are holding the budgets, particularly within governments? I would say it's I've seen too many very, very good and competent advocates be effectively snow-blinded in meetings with treasuries and finance ministries with economic jargon and technical speak, which is about economics and not about health. And so I think being able to speak the language of finance, even just in a small way, can go a long way to then communicating well with those that ultimately can release additional funding.
So knowing who you're talking to and how to communicate to your audience particular is what I hear you saying.
Yeah, absolutely. And also understanding as well that often for health ministries, they want to give more finance into different areas, into all areas, but ultimately they're also having a conversation with finance ministries as well.
Absolutely. So thank you. Thanks a lot. Thank you for those comments. We're moving towards time for some discussion, but I want to give each of our speakers a chance, and maybe James, I'll start with you and go in reverse to say just what's a takeaway that you have learned from this work that you would like to share with the audience?
So mine's fairly simple, I'm afraid, and it's that everybody has the ability to be an advocate, and actually, without everybody advocating, we won't achieve success. It's not just about say civil society organizations. It's not just about campaigning on social media or in the streets, or it's about all of us working together and having good coordination on what we're doing. Everybody here is an advocate. I've heard them advocating today for what they're doing, and it's fantastic work, and it's certainly, I think, would influence lots of people. So I think that, get out there, advocate for what you're doing, advocate for what other people are doing, find other campaigners, champions, advocates, and work with them in a coordinated way, because we all have the ability to advocate for more and to achieve that success.
Great. So working, and I think that last point is really important, that this issue requires a community of people advocating and working together. Lydia, can you give us a takeaway from your work?
Yeah, I think the key takeaway would relate to integrating care for people with more serious and chronic mental illnesses, and just thinking about integrated care models, how important it is to try to apply the essential components of integrated care models, but just how creative we need to be in adapting for the unique needs of the populations.
Great. And Janelle, any key takeaways you'd like to share?
I believe that in order to optimize HIV treatment or treatment for any kind of chronic condition, psychosocial factors have to be addressed, and that care and support has to be delivered in a holistic manner.
Okay, thank you. And Gloria, what would be your takeaways?
So for me, from our experience, integrating mental health in HIV services, it's not a one size fits all. It's very, very critical for one to really look and be very honest about the barriers, the enablers, and best tailor make a program that's best speaking to what's obtaining on the ground. And secondly, coming from a resource limited setting, collaboration is very, very key for successful mental health integration with HIV. And for us, getting the full buy-in of Ministry of Health, both the mental health unit and the HIV program is very, very critical.
Right. So getting those partners that you need across the range. Belinda, tell us about key takeaways from your perspective.
Sure. My main key takeaway would be continued investment in the healthcare workers that are stationed at the treatment and care sites. As James said, anyone and everyone is an advocate, and they're really the persons interacting with the PLHIV population day in and day out. And they should be equipped to really carry out the integration of mental health services in whatever way possible, and continued training, continued investment. It definitely should not be a one-time initiative. It definitely should be ongoing.
Great, thank you. Thank you for those. So it looks like we have questions coming in, and I want to, before we go to the questions, I do want to share a source of information and guidance around integrating mental health and HIV care. And I'm going to see if I can quickly share my screen and remind everyone that in May of 2022, UNAIDS launched this document, Integration of Mental Health and HIV Interventions, Key Considerations. This is a great work that I and many others were involved in, that is a broad guide that helps you to think about the various domains of both integrating mental health into HIV services along the HIV care continuum, but also reminds us that we can also take HIV services to mental health care services as well. So this is a great guide. You can download it from the internet, you can Google it, and I'll see if we can put the link in the chat at some time during this conversation. But I'm going to stop sharing, and let's go to the questions and answers. And let's start at the top. So we have a question for Belinda. In Trinidad and Tobago, what can be put in place to establish or strengthen the feedback loop from the mental health sites to the treatment sites? With the referral protocol that I think maybe that your technical working group will be developing, would it address this?
Yeah, I think that is definitely something that we can look into as we continue to meet with the members of the technical working group. The responsibility of communication really lies with those regional health authorities that I mentioned. And so it can take some doing for us to really figure out how the communication would happen on a day-to-day basis in a very practical manner. So it's definitely something we can address. I don't think I can give an absolute answer right now as to, yes, we will definitely be able to rectify that issue with the referral pathway at this moment, but we can look at it. Thank you.
Thank you. One of our audience members is wondering, what are some of the most common presenting problems that you see at the various sites? So maybe from King County to Trinidad, Jamaica, Zimbabwe, what are some of the I think this means the presenting mental health symptoms or problems that you're seeing? Anybody want to jump in on that one?
I'll start from Zimbabwe. Given that we are supporting the HIV program, integrating mental health from that angle, and also the algorithm that we use for screening, it's mostly depression, anxiety. Those are the common conditions that we identify, and substance abuse. I think those are the three that I would say top the list.
Okay.
Yeah.
Thank you. Belinda or Janelle, do you want to add to that?
Sure. Oh, sorry, Janelle, go ahead.
No, I was going to say it's similar for us here in Jamaica as well. Post-traumatic stress disorder, as I mentioned before, is prevalent, about 40% of persons living with HIV, followed by alcohol misuse and depression.
Okay.
Yeah. And to add to what Gloria and Janelle mentioned, in Trinidad, we also see a prevalence of psychotic disorders, as well as personality disorders. They are not as prevalent as depression and anxiety or substance use disorders, but they are frequent occurrences as well.
Okay, so we're seeing everything from psychosis to the more common depression and anxiety. And I think Gloria made a good point that we're also, in many clinics, people are actually assessing for depression. So you're more likely to identify the things that are being assessed specifically.
Pam, I'll just chime in that I think King
Yes.
County generally is similar. Common mental disorders are common. And then we have very high rates of opioid use disorder and methamphetamine use disorder. But in the low barrier clinic, I think what was really striking was just the high rates of trauma and then complex psychiatric comorbidity. So not only chronic mental disorders, but multiple mental disorders that were just, it's just challenging to develop a treatment plan.
Yeah, this is, what I'm thinking about as I'm hearing all of you speak is that it's be really helpful, I think, to dive into even more deeply in some of the guidance that we're offering around how do you think about people presenting across that care continuum, from people with very complex, multiple social challenges, as well as symptomatic issues and persistent symptoms, all the way to, of course, people who have even transient distress and simply need to understand how best they can also provide their own self-care. Let's see. We've got quite a number. I'm gonna skip around so I make sure we're getting different people asking questions. So I see one question that says, can you tell me how long are HIV patients and those with mental health problems under the supervision of a psychologist and a social worker? Are there documents developed for multidisciplinary patient support? So maybe one way to answer this might be for those of you who are supporting the delivery of specific interventions. So maybe I'll start with Janelle, because if somebody's referred to a psychologist, how long do they actually stay? How long do they engage in care with that psychologist? And does a social worker stay with them throughout their entire enrollment in the clinic, or how does that work?
So I would say that the social worker would probably have a longer relationship with the patient, but then again, I think that's dependent on the patient's needs and diagnoses, etc. So it's a little hard to give an exact answer, but I would say the social worker generally would have that kind of longer relationship with the patient, and the psychologist would be as needed, so to speak. But then one of the unfortunate parts about how our system is set up, it does not facilitate a patient being able to see the psychologist weekly for therapy. It's not that kind of a setup where you get weekly appointments. It's possible, but it is not the norm. And I think that's also one area that could be strengthened.
So you raise a really great point, because I think a lot of people who are doing the integration to HIV are learning to think about more flexible ways of delivering, particularly psychological interventions, because people don't come for weekly HIV care and treatment. And increasingly people have even fewer encounters with the clinic ideally. So whether that's a monthly encounter, whether that's every 3 months, what does that mean for providing? I think it means getting more creative. And you've all mentioned the roles of the psychosocial support person, the patient advocate, peers. So there are many people that someone might have an encounter with, but it's not necessarily going to be the psychologist, and that's not likely to happen weekly. I think that's a great point, Janelle.
Yeah, if I can.
Oh, sorry. I was just saying, and if I could just add to that to say that that's part of the reason why we try to train up the rest of the staff in various techniques, or at least have them be aware of certain things, because of the fact that they may see the patients more often than the psychologist and might have a greater rapport, and therefore the patient might open up about certain things with them as opposed to the psychologist.
Yeah, I was just going to add, Pamela, just similar to what you had said about that we do have manuals for behavioral activation and problem solving therapy that are typically 8 to 12 sessions that we use in primary care. They work really well in the research studies. And then what we find in routine clinical settings is people just don't engage. They're sort of scheduled to come every 2 weeks for 30 minutes and typically don't. And with the low barrier clinic, we developed this really wonderful manual of behavioral activation that I'm happy to share. And just people had really unpredictable follow-up. So that was one of our primary lessons learned, is how do we think about really ultra brief interventions and even single session work? And so really excited about exploring what can someone do with 15 minutes when you don't know when the next visit is going to be. So that's kind of an exciting new development, I think.
Yeah, thank you for that. That's actually I'm glad you brought that up, Lydia. Okay, I want to, noting that we have just 2 minutes and I know that we can't get to everyone here. I see one question that says, an increased focus is given to newly diagnosed PL-HIVs, people living with HIV, and their psychosocial needs. Do you see an equally increased need to target and address the psychosocial needs of our growing population of people living with HIV? And how do we begin this targeted support? As I think the question is, as the population of people living with HIV grows in some communities, how do we really give some targeted support to those in need? And I wonder if this is related to when people are newly entering care, ensuring that they get a thorough assessment, a thorough mental health and psychosocial assessment, maybe making sure that above all, it's the new people who are joining treatment, that we're sure that they get that kind of treatment intervention.
Yeah, Pamela, I just wanted to say in response to that, I think that once persons are newly enrolled in care, it's important for them to receive sort of like an optimal package of psychosocial support, where they're screened for psychological distress and interventions are given as soon as possible. But I also think that routine psychological screening for distress should occur throughout care, because persons may not present with distress upon diagnosis or upon enrollment or 2 years into treatment, but they may, at 10 years, they're really experiencing pill burden, they're really having some social factors that are overwhelming for them, and their coping ability is being diminished. And so routine screening can be quite helpful in providing ongoing psychological care for persons throughout their time in treatment.
Thank you, Belinda. So continuing to provide routine screening in context where Belinda is describing, where there is somebody that can respond to a need if the person screens positive for some kind of intervention. We have a lot of questions that we have not been able to answer It does look as if people are also interested, James, and about communication. You mentioned, James, is there any place that people could go that you might think of if they want to learn more about how to communicate messages and advocate?
What I can do is I can just put a link in the chat to the area of our website about this issue in particular. You can just see what we're doing.
That'd be great. Thank you so much. So we are at the hour, and this webinar is being recorded and will be available on the Mental Health Innovation Network's website. So I want to thank all of the panelists. Thank you so much for being with us. I'd like to thank the Mental Health Innovation Network for hosting us, and would love to invite you all to look at that website, look at the UW BIRCH website, UW-BIRCH, United for Global Mental Health website, the ITech website. All of us are linked in many ways, and just want to also remind you that we value this conversation with practitioners who are doing this work, who are advocating for this work, because it's helpful to learn from each other, and it's also a way that we continue to generate knowledge and to generate questions that we can answer through research as well. So with that, I'd like to bring the session to a close. Thanks, everyone. See you soon.
Thank you.